right. Well, good morning. I'm Kathy Schroeder, President of Cancer Services of New Mexico, and I welcome everyone to our virtual Family Cancer Retreat. Thank you for spending your weekend with us. We truly appreciate it. A bit about the organization and the Family Cancer Retreat. When we started the Family Cancer Retreat in 2002, the program served 50 people from 23 families. Yet we had only begun to address the depth of need for this type of program. There are approximately 100,000 new Mexicans coping with cancer or living with cancer, and 10,000 new cases are diagnosed each year. The program has experienced a consistent growth to the point where we decided to add an extra retreat to the year. So we now hold retreats twice a year. Generally, it's a 3-day in-person event, but if you wish to come to an in-person event, that next one is in September. The program has grown to become the largest general cancer education program in New Mexico and the largest program of its type in the U.S. In 2015, we are proud to announce that we received the national recognition from the Cancer Patient Education Network as a recipient of its 2015 Excellence in Patient Education. So we are fortunate to have amazing support from New Mexico's medical community with over 35 speakers and presenters this weekend. Many of you will see your healthcare providers over the course of the weekend, so please thank them the next time you see them. We also have many terrific financial supporters, most of whom were happy to support the program in this virtual format. We also have a number of individual contributors who have donated to our Sponsor a Family program. Please take the time to review our Sponsor Family donors listed on the virtual background. Most are former retreat participants who chose to pay it forward to let others attend the program. I want to also thank our virtual retreat planning committee, who did an excellent job, and they will be, all of them will be the hosts during the sessions this weekend. So please thank them as well. This is our first topic is Cancer 101 with Dr. Thomas Schroeder. He is a radiation oncologist at UNM and currently serves as the medical director of radiation oncology. He completed his residency at Baylor College of Medicine, Houston, Texas. One focus of his studies was advanced radiation techniques for treating prostate cancer after prostatectomy. He also completed a fellowship sponsored by the American Brachytherapy Society to study radioactive seed implantation at the Seattle Prostate Institute. His interests include image-guided radiation therapy and stereotactic body radiation therapy. Dr. Schroeder grew up in Santa Fe, New Mexico, and attended UNM Medical School, where he also completed an internship in internal medicine. Prior to medical school, he earned a bachelor in physics at the Colorado College and a master's degree in aerospace engineering from Stanford University. He and his family, including twin daughters and a son, are thrilled to live in New Mexico, where they occasionally get to enjoy hiking, camping, and fly fishing. Thank you, and welcome, Dr. Schroeder.
Good morning, everybody. As she said, I'm Tom Schroeder, and I'm going to give you a talk on Cancer 101. Let me share my screen here. Hopefully that's up and you guys can see it. Looks like you can. And I'll get started. All right. So before I get into the talk, I'm going to tell you what I tell you. And then if I have time, I'll tell you what I told you. And then we can answer some questions. Feel free to type in questions as we go along, and I'll try to answer them during the talk. There's a lot to cover, so I'm going to move pretty fast. So first, we're going to talk about what is cancer. We'll go over a cancer treatment timeline so you can see kind of what's involved in the treatment of cancer. We'll talk a little bit about cancer screening, then how we diagnose cancer, then how we stage cancer. We'll do some cancer treatment basics, and then I'll talk a little bit more about cancer clinical trials, which is an important aspect of what we do. Then we'll answer questions. Okay, so what is cancer? Webster says it's a malignant tumor of potential unlimited growth that expands locally by invading into other tissues and throughout the body by metastasis. There's over 200 different types of cancer. I've listed a whole bunch of them there. I'm sorry if I didn't list yours or your family members. What you should know about cancer is it's a mixed bag. There's a lot of different types of cancers. Some are very aggressive, and some actually don't require any treatment. So cancer really starts off with what I would call a bad cell. The cells are what make us up. Each cell has a function in place. And when you get cancer, you get mutations within the cancer, and that causes those cells to divide without control. And then it starts growing into places that it doesn't belong. It violates the borders that are normally there, that keep one tissue separate from another tissue, and can spread throughout the body via metastasis. So normal cells divide and replace cells that die, grow only where they belong, and do not grow into other organs. Cancer cells, on the other hand, divide without control, grow into tissues where they do not belong, and grow into distant organs when they do not belong. And this is the difference between a balanced body where we have homeostasis and unbalanced where we actually have disease. So there's kind of three different ways that cancer can spread. It can spread by direct extension, where it grows into tissues next to the original site where the cancer developed. It can spread along the lymphatics, which I'll go into a little bit more in a second here, and get into lymph nodes. And it can also grow through the bloodstream. So it gets in the bloodstream, flows through the bloodstream, lodges in a different organ or in different tissues, and grows there. So your lymphatic system, this kind of gets forgotten in high school biology. It's a part of your circulatory system. And what it really does is it picks up the fluid that's left behind when the arteries take blood out to tissues and the veins take blood back. There's a little bit of tissue that's left behind that represents about 1 or 2% of the fluid that flows through the tissues. And that fluid then gets picked up by a whole nother set of small vessels that then bring the fluid back to the circulatory system in the chest. Lymph nodes are little tiny filters that sit on that system, and they look at the fluid that comes by, and that's where your immune system is. Your immune system, part of your immune system, sits there and looks at the fluid going by and looks for signs of infection or disease. Then your lymph nodes can rally your immune system to attack the infection. Unfortunately, cancer likes to spread along these pathways, and they lodge in the lymph nodes. And so frequently we will remove lymph nodes or biopsy lymph nodes to look for evidence of cancer. Okay, now we're on to the cancer treatment timeline. The first thing that happens in the cancer treatment timeline is either the patient develops symptoms or they go through a screening test. A screening test would be a test where we're looking for evidence of cancer in an otherwise healthy individual. Once we've got those symptoms or we see something on screening that doesn't look correct, the next thing that usually takes place is a biopsy. And that's where we try to obtain a small amount of the cancer to look at under the microscope to prove that it is indeed cancer and to make the diagnosis. There's a lot of different ways that we can do the biopsy. Sometimes it's just taking blood. Sometimes it's a needle that we place in the tumor and remove a small amount. And sometimes we're cutting into the body in order to remove a piece of that tumor to prove that there's cancer. Once we've diagnosed cancer, then we move on to staging. Staging is where we do a series of examinations that can include laboratory tests or imaging tests, and sometimes even small surgeries in order to determine the extent of the cancer. The extent of the cancer is then evaluated, and we usually group patients into different stages. And I'll go over some staging information and examples in a minute. After that, we do treatment, and treatment can consist of lots of different things, especially these days where the treatment of cancer has become very complex. So we're talking about surgery, chemotherapy, radiation therapy, which is what I do, and other forms of therapy that may be beneficial for patients. After we've usually done a round of treatment, then you go into a mode of surveillance. So if we get rid of all your visible cancer, then we will follow, doing examinations or imaging tests in order to look to see that the cancer has not returned. If it returns, then you go back to treatment again, and then you go back to surveillance again. And sometimes treatment and surveillance kind of go together. Okay, let's talk a little bit about cancer screening, which is the first of those steps in the cancer treatment timeline. These are tests that we perform on an otherwise healthy individual to check to see if there's any evidence of cancer in their body. The most common tests out there, standard tests, include mammography. This is generally performed in women, recommended ages 50 to 74. It's not uncommon for us to do mammography before that, and it's not uncommon for us to do mammography in women older than 74. We also recommend colonoscopy in adults. That number says 50 to 75, but actually they're starting to do it in younger individuals because colon cancer is showing up in people in their 40s. So right now, I think they're recommending screening of 45. And if you have family history of colon cancer, it may even be done earlier. Once again, we usually stop at 75, but sometimes we'll go later, especially in somebody who's, thought to be living for a lot longer. A really old, common one, probably the first screening test, is a pap smear. That's to look for the evidence of cervical cancer in women. And they say women up to 65, but again, sometimes we will do it after 65, depending upon the specifics. Usually this starts when you're younger, either a teenager or in your 20s. CT for lung cancer is a newer screening test where we do a fast, low-dose, non-contrasted CAT scan to look for evidence of lung cancer in people who have a smoking history. I believe the current recommendation is if you've smoked 1 pack per day for more than 20 years, then we want to look at your lungs periodically to check for the evidence of cancer. That typically starts at age 50, but in some cases can start sooner. And those are the standard tests. Now, there's some other tests that are commonly performed where we're looking for cancer in an otherwise healthy individual. One of them is the PSA for prostate cancer. That's a screening test I would recommend. This is just a blood test where we're looking for a protein in the blood. In the case of prostate cancer, that protein, there's more of that protein in the blood. And more importantly, the amount of that protein in the blood goes up over time. And so some doctors like to screen their patients for that to look for prostate cancer. It's a little controversial because after that, a biopsy can be performed, which is not the easiest thing to have performed on a patient. But frequently a PSA can be elevated and patients not have cancer. So this is not, a standard test, but that's close to a standard test. Ultrasound for women who have ovarian cancer, mammography in women less than 50, MRI looking for evidence of breast cancer. All these can also be used as screening tests, but typically are only used in women who have an increased family history of those types of cancers. And there are others, including blood tests and things that are done, especially in people who have a family history of cancer. So the cancer diagnosis is almost always requires a biopsy. So we're taking a little bit of that tissue, with a surgical procedure or a needle biopsy, or if we're talking about a leukemia, sometimes they'll do a bone marrow biopsy or just take blood. And then we're looking under the microscope, specifically a pathologist looks under the microscope, and they look for evidence of cancer. And with that, they can also get other information about the cancer. They can see how aggressive the cancer looks under the microscope, and they can look to sometimes see what type of cancer it is. Also, these days, we can do elaborate genetic tests on the cancer to look for specific mutations that can sometimes affect treatment and prognosis. So the grade of the cancer. The way they establish the grade of the cancer is when they're looking under the microscope, they try to see how much that cancer replicates its existing organ. In other words, cells that turn cancerous sometimes will try to behave like they're supposed to. They don't do a perfect job of it, but they try. And we can see evidence of that in the way that they align themselves. Mostly this is in cancer cells that come from glandular tissue, like breast cancer or prostate cancer, or even colon cancer. And they try to form small glands where the cells are around the outside and there's a little central area. As the cancer becomes more aggressive and less like normal tissue, those glands start to become smaller or less prevalent, and you start to get cells that just grow in sheets. The other thing that we can look at is how many of the cells are undergoing division, what's called mitosis. And we can sometimes see that on just a plain examination under the microscope. And sometimes we can use special tests to see if certain enzymes are upregulated that are part of that process. So the higher grade goes with more mitoses and more dedifferentiation, meaning it looks less like the tissue of origin. Cancer staging. So this is where we do examinations to see how far the cancer has spread. On the right here, you'll see a PET scan. And in this PET scan, you're going to see a cancer that's in the lung right here that's lighting up. You'll also see some lighting up down here. Some of this looks like it's just normal stuff in the kidney. This actually may be a metastasis to an adrenal gland, hard to tell on this picture. But we will do those types of tests, PET scans, CT scans, MRIs, ultrasounds, blood tests, and sometimes we'll even do tests where we remove lymph nodes to look if there's involvement of those lymph nodes. Okay, cancer staging. So the most common cancer staging system, this is not used in all cancers, but is used in many cancers, is what's called the TNM staging system. The TNM stands for T, which is the T stage, which relates to the tumor, T for tumor, which looks at the size of the tumor, how much it's invaded into the tissues, what tissues it's invaded into, and other things depending upon the type of cancer that you have. The N stage in this case stands for lymph node, N for lymph node, which will look at the number of lymph nodes involved, the location of those lymph nodes, how big the cancer is in those lymph nodes, whether the cancer has grown through the edge of the lymph nodes, etc. And then the M stage is whether the cancer has spread to distant organs. This is where the cancer is, for instance, if you have a colon cancer and it spreads to your liver, we would then assign an M stage to it. And typically these get 4 stages for T stage. The N stage can vary dramatically from just having 0 or 1 to having 0, 1, 2, and 3. And the M stage can sometimes be 1, and they sometimes annotate it depending upon which organs have been involved with the metastasis. Over here, you'll see that it's common for us to give a stage on top of this T, N, and M. So we use the T, N, and M to determine the stage that's usually 1 to 4. Stage 1 is typically disease that's localized and small. Stage 2 is where the disease is a little more advanced, where the the T stage is higher, but you may not have end stage, or you have a very early end stage. And stage 3 is where you've got T and a lot of N. And stage 4 is typically where you have metastasis. But these vary depending upon the type of cancer that you have. Okay, moving on to cancer treatment. There are a lot of different cancer treatment modalities these days, but we typically divide them up into surgery, which can be done a bunch of different ways, and I think I have a little more on that on the next slide. Chemotherapy, which these days is probably better to say systemic therapy. This is where you see a medical oncologist and they're going to give you infusions of a drug. And sometimes that's a traditional chemotherapy agent, but sometimes it can be something like immunotherapy or molecular therapy. This type of treatment, one of the benefits of this type of treatment is that typically it goes all over the body. So when you give chemotherapy, it's going all over the body, so that can treat the cancer that may have spread to other parts of the body. And then radiation therapy, which is a localized treatment, which means we're directing it to one part of the body. And we do that in an effort to kill the cancer that we can see, or sometimes kill cancer that we think may be there or has a high probability of being there based on your stage and your type of cancer. And there's also other treatments, including supportive therapy treatments, which involve physical therapy, occupational therapy. Sometimes your provider may even recommend that you have acupuncture or non-traditional types of treatment. All right, surgery. Here's some example of surgery. Surgery can be a big surgery where we're, cutting open your abdomen to remove part or all of your pancreas. And it can be something small where we're just putting a needle into you in order to try and kill the tissues with one form or another. There's all sorts of fancy ways to do that. On the left here, I've got a robot where the robot does the surgery inside the body at the guidance of the surgeon. And on the right here, you can see this is a needle going into a lung tumor where they're either getting a biopsy or they may even be doing a heat treatment for that or some other form of treatment. Okay, chemotherapy. These days, chemotherapy consists of many different systemic therapies for cancer. And this can include old-fashioned chemotherapy where we're literally poisoning the cancer, which also poisons you a little bit. The cancer gets poisoned much more with these types of treatments than the rest of your body. And it's usually given in cycles where we give you one treatment and then we wait a period of time before we give you the next. This can be associated with side effects like loss of hair, nausea, vomiting, and fatigue. There are also modern treatments, which are different agents. These are agents that are designed to get your immune system to attack the cancer, which we refer to as immune therapy. And it can also consist of molecular therapy. And this is where we're inhibiting certain chemical pathways that cause the cancer to grow. These pathways sometimes are upregulated, meaning they're much more prevalent in the cancer cells. So we can give you these drugs that block those pathways to prevent the cancer from growing. And then here's radiation therapy, which I've talked about a little bit before. There's a lot of different ways in which we can give radiation therapy. Usually this is targeted at specific parts of the body or regions of the body. In the center here, you can see this is a head and neck cancer treatment where we're actually treating the lymph node areas. And in this area, we're probably giving a higher dose to treat the back of the throat where the cancer probably came from. And we're also sparing areas like the larynx and the spinal cord. We can sometimes also do radiation therapy by inserting either temporarily or permanently radioactive sources into specific parts inside the body. And when we do this, that radioactive source will radiate from the inside out, giving a very high dose of radiation to the area we want and keeping the radiation from affecting other parts of the body. Most of what we do is what's called external beam radiation therapy, where we're shooting X-rays at a specific part of your body with a device such as this. But on occasion, we do this insertion of radioactive sources, which is referred to as brachytherapy. In this case, this is a depiction or a diagram of where we're putting radioactive seeds inside a patient with prostate cancer. So there's a lot of other complementary therapies, including acupressure and acupuncture, and other things that have been proven to be helpful. And your provider may recommend those things, or it may be a good idea for you to pursue those things. If you are pursuing those things, I would recommend that you tell your oncologist what you're doing so that we don't run into a situation where there's effects between the two that are not something we want. Okay, now we get to my favorite part of this, which is what are cancer clinical trials? We're going to talk a little bit about cancer clinical trials because this helps us to really guide what kind of treatments that we recommend for patients. And what these are research studies that are involving people with cancer and treatments of cancer, or diagnosis of cancer, or screening of cancer, any one of those things along that cancer pathway. And really what we're looking for is to answer questions about the cancer so that we can better treat, diagnose, or prevent cancer. And there are different types of clinical trials out there and different phases of clinical trials, which I'll go into. And typically they follow strict scientific guidelines through what's called a protocol. Okay, so let's just delve into some types of clinical studies. So there's treatment trials. That's where we're giving a new treatment or a different treatment compared to the standard treatment. And these are to help treat the cancer. These are probably the most prevalent. There are also prevention trials. So patients that we know are at increased risk of cancer, we may recommend a treatment to sort of prevent the development of that cancer. There's also early detection trials. These are sometimes referred to as screening trials. This is where we're trying to find a way to identify these cancers earlier in the patient so we have a better chance of curing them. There's also diagnostic trials. This is where we're trying to find better ways to diagnose or stage a cancer. And then there's also quality of life trials where we're changing the treatments in order to get a better quality of life for the patient. So all of these are probably available through your oncologist, and you can ask your oncologist about them. So here's an example of a treatment trial. This one is a fairly famous one done in England. It's called the PROTECT study. And what they did on this study is they took patients with early prostate cancer and they randomized them, which means they randomly assessed them to one of three treatments. And those three treatments were observation, where they weren't going to do any treatment, surgery, where they were surgically removing the prostate, and radiation therapy, where we were radiating the prostate. And what I'm showing you here on this graph is the prostate cancer specific survival. This means 100% right here, noted as 1, is the fraction of people that have died from prostate cancer. So 1 means none have died from prostate cancer. They're all alive. And then over time on the bottom here, which is years, you can see over time, very few of the patients died from prostate cancer. And if you look at this, you can see that there's a red line for prostatectomy. That's where we remove the prostate, a blue line for radiation, and a dotted line for active monitoring. So as you can see, there's really no difference as far as dying from prostate cancer between these treatments in this group of patients. The next curve over here, this is the freedom from metastasis or metastasis-free survival. This is looking at how many of these patients developed metastases. In other words, spread of the cancer to other parts of the body. At the beginning, time 0, nobody had. But as time went along, some of them did. And then the more they did, the more this curve bends downward. And as you can see here, in the group that got observation, there was a little bit more development of metastasis than in the groups that got radiation or got surgery. Okay, here's an example of a prevention trial. So in this case, this was done here in the United States by the National Cancer Institute, which is part of the National Institutes of Health. They took patients, men who were at risk of developing prostate cancer, which is pretty much just regular men, and they randomized them to receiving vitamin E and another drug called selenium, which is actually kind of like a vitamin, versus getting a placebo. Now, selenium and vitamin E were thought to help prevent prostate cancer. And so the National Cancer Institute wanted to test to see if this was true. So they took a large group of men, in this case, it was 35,000 men from 427 different sites in the United States, Canada, and Puerto Rico. And they randomly assigned them to getting a placebo or getting selenium and vitamin E. And then they looked over time to see how many of them got prostate cancer. And if you look, this is the incidence of prostate cancer. So this is the likelihood that the group developed prostate cancer. And this is, a very small amount, 1% here up to 10%. And you can see over time, the patients that actually got the vitamin E and selenium were a little bit more likely to develop prostate cancer than the group that got the placebo. This was a surprise to them because they actually thought that the vitamin E and selenium was going to be effective in preventing prostate cancer, and it actually proved to be detrimental. This one was big in the news, about 15 years ago. Okay, here's another one on detection. They're looking at mortality related to prostate cancer screening. So what they did is they took 20,000 men and they randomized them to either get PSA tested every 2 years or not. And then they followed them over time to see how many of them actually ended up dying from prostate cancer and how many didn't. And this shows what happened to them over time. So this is the number of people who died of prostate cancer as a percentage. This is 0.2%, 0.4%, 0.6%, all the way up to 1%. And as you can see, over time, there was no difference for the first 6 or 7 years. And then they started to separate where the group that got screening did better than the group that didn't. And by the time we're out here to 14 years, there was a pretty big difference between the group in the control group and the group that was in the screening group. Please remember, though, the numbers are very, very small. We're talking about 1% after 14 years. This is another study using prostate-specific antigen as a serum marker for adenocarcinoma of the prostate. This is the study that actually, I believe, got PSA FDA approval as a study, as what we would call a tumor marker. So in other words, we can follow your prostate cancer by looking at this PSA antigen inside your blood. And this really changed prostate cancer when this article came out in 1987. And here's an examination of quality of life trial. So in this case, they were using a drug called amifostine that they were infusing into the rectum in order to protect the rectum while patients underwent radiation for prostate cancer. Amifostine was actually a drug created by the Department of Defense to try and protect soldiers during times of nuclear war when they were exposed to radiation. It didn't really work well for that, But through technology transfer, it made its way into medicine, where they tried to use it as a radioprotective agent in patients with prostate cancer. Unfortunately, it didn't really work. It kind of had more problems than it had benefit. And so this no longer is really recommended by anybody, and the drug has fallen into disuse. All right, next I'm going to talk a little bit about phases of clinical trials. The phases are basically there's 4 phases: 1, 2, 3, and 4. The phase 1 studies are when we have a brand new drug that we've really never tried in humans. We've proven in laboratory tests using cultures of cancer cells and other tests in animals to show that the drug appears to have activity against a certain cancer, but we've never really tried it in humans. And so what we're looking for when we give this drug is the drug safe, and what is the dose that's safe? And these is typically in small number of people looking for a treatment after they've exhausted all other treatments. The phase 2 study is where we take one of the phase 1 drugs that looks to be promising, and we try it in a small group of people. Typically, this is less than 100, but it can be more than 100 and has been more than 100. And what we're doing is we're giving all of these participants the drug, and we're looking to see how well the treatment works compared to standard treatments and historical data of standard treatments. These are probably some of the most prevalent studies around, where we're trying to get drugs to see if they do better than standard treatments. When we've got one of these that looks really promising, we do a phase 3 study. And a phase 3 study is where we're taking a large group of patients that have the cancer, and we're either giving them the standard treatment or we're giving them the new treatment that's supposed to be better. This is a comparison study, and this is typically what the FDA looks for before they're going to approve a drug. Sometimes they will do it based on phase 2 studies, especially in cancers that are more rare, but usually they like to see one of these phase 3 studies that proves that the new treatment is better than the existing treatment. And then the phase 4 studies is where we're longitudinally, meaning over a long period of time, examining some of these drugs, which frequently we haven't looked at for long periods of time. So these are where we're looking at thousands of patients, monitoring them, usually rather loosely, but looking at them to see if long-term complications come up. So if something happens weird to them 10 years after giving the drug, that sort of thing, so that we make sure that these drugs that we've found, developed, and proven are safe over a long period of time. Okay, so we really like patients to participate in these clinical trials, but it turns out that people frequently don't like to. And these days, only about 3% of adults with cancer participate in clinical trials. This is very different than in children, where this number is markedly higher. It's probably 70, 80, or 90% of kids participate in clinical trials. Because cancer is so rare, we really encourage participation in children, because we really want to move things forward, and their cancers are really different than those in adults. But some of the barriers in the adult population is they just don't know there are clinical trials. They don't have access to clinical trials. They kind of are afraid of them or distrust clinical trials because they don't want to be experimented on. And they have maybe practical or personal obstacles to this, like they can't get to the clinic in order to participate because they live rurally, or they have insurance or money problems that prevent that from happening. And sometimes their personal physician may say, "Oh, I don't want you participating in a clinical trial." That's actually pretty rare. And sometimes they just can't understand, or we can't communicate with them effectively, the purpose of the clinical trial because of their cultural or ethnic background. And also, if they don't speak English, sometimes language can become a problem. And if they can't read all of the consent forms and things like that, literacy can be a problem. So we struggle to try and remove as many of these barriers as possible in our patient population so that we can get participation in our clinical trials. If you're interested in participating in a clinical trials, there's a lot of different ways that you can do this. There's the New Mexico Cancer Care Alliance, which has changed its name to the New Mexico Clinical Research Association. So this nmcca.org may refer you to a different site. This allows a lot of providers in New Mexico access to clinical trials through this organization, which is a very good organization. And if you want to look at a broader area, you can look at clinical trials nationally by going to www.cancer.gov or clinicaltrials.gov. There's also the Coalition of Cancer Cooperative Groups. They can help you get onto trials. Probably the best one to go to is this. It's a little bit complicated because you'll see how many clinical trials are out there. There's a whole bunch. And I think that got us to the end, and I'll take any questions if you got them. I didn't see any hands raised, and I didn't see any open questions, but I'll take them now if you guys want them.
Can you, while we have you on here and we're waiting, something that my program manager and I were talking about is is just how interesting immunotherapy is. Could you maybe describe a little bit about that real quick?
Yeah, so immunotherapy is kind of a broad term where we're doing something to try and stimulate the immune system to attack your cancer. And honestly, the concept for this has been around a long time. In the 1960s, when we first started developing and studying antibodies. So antibodies are little proteins created by your immune system that stick to cells that are infected with viruses or stick to proteins on the surface of bacteria or other infections and get your immune system to attack those. They're kind of like little flags that say, this guy's bad, come and get him, okay? And so antibodies were one of the first big ways that we tried to use the immune system against the cancer. And it's right now the most common way. So what we do in this case is we're giving you specialized antibodies that are designed to stick to your cancer. Now, most of the time, these antibodies are designed to stick to, little proteins on the cancer that are much more common on the cancer than are on the rest of your normal body. And then the idea is that your immune system attacks these. The first one of these that was developed in the 1990s was a drug called Rituxan, and it was given for patients with lymphoma and is still used to this day as it is highly effective on multiple forms of lymphoma. This is also used to treat breast cancer with something called trastuzumab or Herceptin, which targets the HER2 antibody, which is upregulated in some forms of breast cancer. And now it's being used in a host of cancers with something called the programmed death ligand, which is another protein that sticks off of many cancers, including lung cancers and kidney cancers, melanoma, and a host of others. And it's designed to stick to those and get your immune system to attack. Now, one of the interesting things about this antibody therapy is sometimes those antibodies stick to these proteins and prevent these proteins from doing their natural function, which may be to make the cancer cell duplicate. So in certain instances, we're not sure how much these antibodies are stimulating the immune system and how much they're inhibiting growth of cancer because they're kind of doing both at the same time.
Hi,
They're
Doctor.
developing more and more of these. There was one in the late 90s, and now there's probably close to in between 50 and 100 of these. Probably closer to 50 than 100, but the new ones of these come out constantly as we're trying to develop ways of getting the immune system to attack the cancer. Now, there are other ways that are more experimental of getting the immune system to attack the cancer. And in fact, one of the early treatments for melanoma was just to sort of excite the immune system in general by giving drugs. Those can be very difficult therapies because when you excite the immune system, you get horrible flu-like symptoms. But we've done that. We've actually introduced bacteria or pieces of bacteria to try and stimulate the immune system to attack the cancer by injecting those into the cancer and other things. All right, I'm going to answer some questions now. So one question is, how often is it safe to do a CAT scan and an MRI? So I'll take the MRI first. MRIs don't really use radiation, and so those are considered to be safe, and they have no known lasting problems with them. We do give a contrast agent frequently when we do an MRI, and there's been some questions about that contrast agent causing problems in a very, very small number of people, and there are people that are allergic to that contrast agent, but otherwise it's very, very safe. As for CAT scans are exposing you to X-rays. Those X-rays can put you at risk of developing cancer in the future, and we've really worried about that. And one of the reasons we've worried about it is because, starting in about 2000, we started doing a lot more CAT scans for everything, not just cancer, but for everything. And we were worried that this was going to increase the rates of cancer in the United States. So back in the 1980s, hundreds of CAT scans were being done. But, starting in 2000 and for the last 20 years, we're talking like upwards of 10 million CAT scans are done in the United States per year. So we've been worried that that may increase the risk of cancer in individuals. So far, we haven't really seen that happen. The epidemiologists that study this haven't really seen it happen, but there is a risk of developing cancer as a result of exposure to X-rays, and CT scans use X-rays. I really wouldn't worry too much about it because, as I've said, this is very, very low risk. We're talking beyond a 1 in a million chance that you could develop a cancer from a CT scan. Next question. So does radiation therapy have a long-term effect on the immune system? Typically not. And this is the radiation that we give can kill parts of your immune system. But typically when we're giving radiation, we're doing it in a focal or localized fashion. So we're only treating a part of the body. And because of that, your immune system, which is kind of everywhere in your body, will compensate. So in other words, we'll kill some of the immune cells when we're giving radiation in that local area, but the other immune cells in the body will just come and fill that in. Now, in the old days, when we treated very large areas of the body, we could end up causing problems, but we haven't done that since like the 1980s, so I'm not too worried about it. Next question. So am I in remission now that I have to take an astrazole for 5 years? Okay, so this is a good question. Remission is actually a term that came about when we first started chemotherapy. So the first chemotherapy out there was something called N-nitrogen mustard. And we figured out this was a good cancer treating agent kind of because of war. So people were getting gassed with mustard gas in World War I and a little bit in World War II. And a pharmacist discovered that some of these guys exposed to the gas ended up having what's called aplastic anemia. In other words, this gas kind of killed their immune system. They weren't able to make blood cells after that, including the white blood cells. And he hypothesized that in lower doses in a patient with leukemia, we might be able to give them this drug and get rid of the leukemic cells. And so when they first started studying it, the way they would study it is, they'd find people with leukemia. They could see the leukemia in their blood by looking at it under the microscope, as we've previously discussed. And then they would give them the N-nitrogen mustard, or as they develop more chemotherapy agents, they'd look inside the blood to see if the cancer went away. And what they found is that they could get the cancer to go away in the bloodstream. The problem is they found later on that even though they got rid of the cancer in the bloodstream, it would come back. And so they started to use the term remission, meaning at least we got rid of it in the bloodstream. Now, that may have not gotten rid of it entirely. So that's where that term comes from. Now, in a breast cancer patient that has an early breast cancer, which I assume that you have, what happens is they usually surgically remove the breast cancer, and then sometimes you'll get radiation and sometimes you'll get chemotherapy. And almost always they recommend hormone therapy afterwards. And what they're doing there is when we cut the breast cancer out, we've removed all the cancer that we can detect in your body. But we know that there is a chance that there may be some microscopic cancer cells left behind that we can't detect. And so we may recommend a form of systemic therapy like hormone therapy, which is designed to suppress the growth of those cancers. And so that's typically a common recommendation after having localized treatment for your breast cancer, is especially if you have hormone receptor positive breast cancer, that you take this hormone therapy for a period of 5 years because it's been proven to decrease recurrences. So I would say that you were cancer-free after you had your surgery. In other words, at that point, we can't see any cancer in your body. And sometimes that's referred to as remission as well.
Thank you very much, Dr. Schroeder. We appreciate your time this morning.
Okay, thanks, everybody.